Okay, so here we have to know when we have to go and choose your typical and atypical. What is going to be the adverse effect? Because we know antipsychotics is basically to treat all your schizophrenia, patient is having a behavioral disorder like a conduct disorder, or a patient having a Tourette syndrome, or a patient who's coming with a bipolar. So these case scenarios we are going to be using. So we also use them in combination. So now we have to know the mechanism of action with respect to typical and atypical. So first, typical antipsychotic psychosis, whenever there are D1 receptors, D2 receptors, they are up to D5 receptors. Okay, there are five types of dopaminergic. So dopaminergic is going to be D1 to D5. So your typical is going to block which of the dopamine. You have to be very specific and you have to know it's going to block your D2. That means they're going and binding to that particular receptor and they are preventing the dopamine from binding that area. Okay, they're preventing your dopamine to go and bind to your D2 because your antipsychotics of typical, they're going and binding in that receptor. Okay. So now we also, because of this particular case scenario, we can have certain positive symptoms. So what are positive symptoms? Can you guys give any examples of positive symptoms of psychotic disorders?
Hyperactivity.
Hallucinations, delusions, disorganized thoughts.
Okay, fine. So whenever a patient is having a behavior, okay, so or let's say disorganized thinking, okay, or even your hallucinations or even your delusions. So these are your positive symptoms. So positive symptoms are because of your increase in your dopamine. Positive symptoms are happening because of increase in your activity of dopamine. Which pathway is affected? Because we just now did neuro, right? So is it mesocortical, mesolimbic, or nigrostriatal? Which pathway is affected? Mesolimbic. Okay, so you have to remember mesolimbic pathway will be affected because that is going to have increased activity of dopamine and certain positive symptoms. Okay, so these symptoms and all are going to be reduced. These symptoms are going to be reduced whenever you give a typical antipsychotic. Okay, so again, please remember you have to divide your typical into how many medications are high potent and how many medications are low potent. Okay, so if giving you examples like haloperidol, your pimozide, triflu, flupenazine, and your chlorpromazine. Okay, so in this, the low potency drugs basically means that you need high doses of them to achieve a particular effect. Okay, let's say your chlorpromazine, that is a low potency drug. Okay, so even very commonly used in India is your prochlorperazine, right? Prochlorperazine is also a low potent drug. Okay, so next is promethazine. Promethazine is also a low potent. Okay, but here only chlorpromazine is given. So chlorpromazine is going to be a low potent drug. So these drugs need a high doses for their effect to be achieved. Okay. So next is these drugs are very, very structurally, for example, I'll write them out. This one, chlorpromazine and prochlorperazine and your promethazine. Okay, so these three drugs you have to remember they're very structurally similar to which drug? TCA. They're very structurally yeah, tricyclic antidepressants. So they're very structurally similar to tricyclic antidepressants. So that means they are going to be able to block your H1, that is histamine. They can block your alpha 1, that is adrenergic, and they can also block your muscarinic acetylcholine receptors. Apart from blocking your D2, apart from blocking your D2, your chlorpromazine and your prochlorperazine and your promethazine, because it's structurally related to your tricyclic antidepressants. So tricyclic antidepressants, what do? Same thing they're going to do. They will block your histamine anticholinergic and your muscarinic anticholinergic receptors and your adrenergic receptors. So this is called as, this together is called as HA. Actually, this is A and this is M. It's called as ham block. Okay, it's called as ham blockade. So now, because of your histamine blockade, what is the patient going to have? So let's say a patient is having ham blockade. Okay, So what will be the most common antihistamine symptom that the patient will always, like the case scenario you will always give?
sleepiness, drowsiness,
Okay. So what is going to be the most common symptom given for antiadrenergic?
hypertension,
Vasodilatation, orthostatic, because please remember orthostatic, okay? Because many people do not know that your levodopa is also going to cause orthostatic hypotension. You have to be very careful. So, and your carbidopa can also not nullify this orthostatic hypotension as a adverse effect, okay? So next is, what is going to be happening when there is anticholinergic? What is your atropine-like effects? Starting with the mouth, they will have a very dry mouth. What will happen to your sweat? Anhidrosis. They have a lack of sleep. What will happen to your mental status and urine? They will have delirium and they will have urinary retention and they will, maybe the heat temperature also can be mentioned. Okay. The overheating can also be mentioned. Okay. So what I'm trying to say is because of this ham blockade, you'll be very oftenly questioned up to all these scenarios. Okay, because of this ham blockade, they can ask about sedation, they can ask about orthostatic hypotension or anhidrosis or dry mouth or your delirium, urinary retention, or the patient is going to be coming with your overheating scenario. Okay, so next is these are low potency drugs, that is your chlorpromazine, prochlorperazine, promethazine are low potency antipsychotics. So what are the high potency antipsychotics? From the examples given here, can you guys name it out?
Haloperidol.
Haldol,
Yeah, haloperidol for sure. And your fluphenazine and your, I think perfenazine is not given here. Okay. So now these high potency drugs and all, they require very low like doses for their effect to be reached. Okay. So that means these drugs, they don't block your ham. Okay. So these drugs, they do not block your ham receptors. Okay. Not up to like your typical ones, like the typical low potency ones. Okay. But they do have certain adverse effects only with respect to your D2 receptor blockade. Okay. Only with respect to D2 receptor blockade, they can have adverse effects. So next is dopamine is blocked. So dopamine is important for what activity in the body? Starting with your nigrostriatal pathway. So why it is important for the nigrostriatal pathway?
Was Parkinson's.
Parkinson's, right.
movement,
So nigrostriatal pathway happens in the, yes, it happens in the basal ganglia. So this is going to prevent your, so the nigrostriatal pathway in the basal ganglia will prevent your involuntary movements. So what are the involuntary movements in the extrapyramidal system? Because whenever involuntary movements is happening, the dopamine is going to be like the neurotransmitter, right? So the extrapyramidal system, okay, the extrapyramidal system is going to be disinhibited. It's going to be disinhibited because of all these medications, okay? Like your high potency antipsychotic especially. So that's why they can have involuntary movements that can happen. So I want you to remember nigrostriatal pathway, which is there in the basal ganglia, that is going to prevent your involuntary movements, which uses your dopamine as a neurotransmitter. So because we are giving antipsychotics that is blocking your dopamine, the patients are going to be having abnormal involuntary movements as an adverse effect. So apart from this, because of this, the patients can also have neuroleptic melanin syndrome, but I will talk about that like detailedly even much. Okay. So as you can see here in the adverse effects, antihistamine is something I told, and antimuscarinic and alpha also, adrenergic also they have given. So one more thing I told right now is your extrapyramidal symptoms, so that you can remember by the mnemonics adapt. Okay, you guys can remember these extrapyramidal symptoms with respect to how the antipsychotics, like typical antipsychotics, how they're going to present. Okay, so now your atypical. Atypical actually has a different mechanism of action, but the main concept is dopamine blockage only. Okay, so atypical has a different mechanism, but the main concept is to block your D. So now, for example, let's take risperidone, okay, or let's take your paliperidone. So these are antagonists at which receptor? Atypical is also antagonist at D2 only. Okay, atypical is also antagonist at D2 also. So they also have one more receptor that is called as 5-HT2A. Okay, they're going to block your D2 and they're going to block your 5-HT2A. Especially what you have to remember is your risperidone is given, no? The risperidone metabolite, okay? The paliperidone is nothing but a metabolite of your risperidone. That's why you have to remember paliperidone will have very few adverse effects. Adverse effects will be very few because it's a metabolite of your risperidone. Okay. Suppose let's say we are having a patient using risperidone and they're having like a hepatic risk, then you can go ahead with paliperidone. Okay. So now we have two receptors that is blocked D2 and 5-HT2A. Okay. So apart from this, okay, they also have an antagonist effect at alpha 1, alpha 2, and H1. So this is D2, 5-HT2A, alpha 1, alpha 2, and your histamine, your H1 receptors, H1, histamine receptors. Okay. So these drugs, when compared to your dope and all these things, they bind to this 5-HT2A a lot. They have a very strong affinity for this. For example, let's take your clozapine. Clozapine will actually block your 5-HT2A or 2C receptors, and it's a very, very weak D2 antagonist. Okay, clozapine is more of a blocker of this than your D2. Okay, so now I will write the receptors again. Okay, I told you D2, alpha 1, alpha 2, H1, and I told you 5-HT2. Actually, there is 2A and 2C. I will write both. And the last is going to be, so the clozapine I told you is more of this. Most of the antipsychotics actually is more of this when compared to the D2. And clozapine is a very, very weak D2 antagonist. Okay, but clozapine can also act at one more thing, that is D4. Okay, it also acts at your D4 and the other dopamine, because I told you in the start there is D1 to D5. Okay, there is D1 to D5. It can also act at your D4 receptor. Okay, this drug is going to increase. Okay, this drug is going to increase the dopamine release in the mesocortical pathway. Okay, but it is inhibiting the dopamine release in the mesolimbic system. Okay, so what do you mean by your clozapine is a weak D2 antagonist? It's a weak D2 antagonist. It's a weak D2 antagonist, but it also acts at your D4. What is the meaning of that? So this means in the mesocortical pathway, it is increasing the dope. Okay, in the mesocortical pathway, it's increasing the dope. And in the mesolimbic pathway, it's decreasing the dope. Okay, that's what you have to understand by this. So clozapine in the mesocortical, it will increase the release of dope. And in the mesolimbic, it will inhibit the dopamine release. So this basically means, like, for example, let's say in the mesolimbic pathway, for those people who have went through your neuro, mesolimbic, they would have given a clinical disorder in the tableau column in the first stage. So can you guys remember that clinical disorder and tell me? It starts with an S. In the positive symptoms, they would have given that this is going to be seen along with this. Anybody?
Schizophrenia.
Yeah, schizophrenia. Okay. So now the positive symptoms are basically seen, the positive and the negative symptoms of your schizophrenia. So now that is going to be like inhibited. So that is going to be combated. Okay. It helps both your negative and your positive symptoms. That's why clozapine is basically a drug. It's reserved for only resistant schizophrenia. Okay. Because apart from the adverse effects, clozapine is known for a lot of adverse effects. For example, let's start from your agranulocytosis. What is the other drug which causes your agranulocytosis? In endocrine, with respect to thyroid?
Thyroxine.
Yeah. So not thyroxine directly, antithyroid drugs. Okay, they cause your agranulocytosis because antithyroid drugs are directed against which enzyme, like which cofactor for converting a reaction like from I minus to I2 to your monoiodine thyrosin and diiodine thyroxine. So what is going to be the helping factor in all of these? TPO, right? Thyroid peroxidase. So antithyroid drugs is going to be inhibiting this. Antithyroid drugs will be inhibiting your propylthiouracil and methimazole. they concentrate on inhibiting this. And even the 5' deiodinase, that is your peripheral conversion of T4 to T3. Okay, that's why when you give your antithyroid drugs, they're not going to stop your TSH, that is your antibodies when they're against your TSH. That can be a little bit stopped, okay? But the other scenarios, for example, the antibodies are still going to be persisting in the body, right? So these can attack the other areas in the body. They can have a agranulocytosis. So here also they have a agranulocytosis because of clozapine, and that's very important. So we will talk about that in detail when we come to endocrine. So agranulocytosis is one adverse effect, and that's why we have to be keeping clozapine as a last case scenario, like treatment resistant schizophrenia. Okay, so till now, what all receptors I told you? I told you D2, alpha 1, alpha 2, H1, D4, and your 5-HT, right? 5-HT2A or 2C. So the other antipsychotics that basically acts on your 5-HT2, this 5-HT2 is also your olanzapine. I'll erase this. Olanzapine, okay, and your quetiapine. So these both also will act at your 5-HT2 receptors. Okay. So now this is your atypical antipsychotics. So when they're having like, a histamine blockade, so what all drugs will have that you should remember. For example, I will just mark it out. I'm not sure if it's given down. Just a minute. Okay. So basically, your clozapine will have a histamine. I'm talking only about histamine blockade. Clozapine will have, olanzapine will have, okay, paliperidone will have, quetiapine will have, risperidone will have, ziprasidone will also have. Okay. So, and one more thing is aripiprazole. Okay. So these all are going to be having your H1 blockade. Okay. So your Ari, Asina, Rosa, Olanzo, Pali, Quetta, Risperi, Zipra. Okay. They all will have H1 blockade. Okay. So this H1 is not just contributing to your sleeping, that is your sedating effect. They're also thinking that it's associated with your weight gain, because in this they would have given weight gain, clozapine, and olanzapine. Okay. The reason for that is they are thinking that your H1 effect is contributing to your sedative effects and your weight gain with many of your antipsychotics that they have given you till here. That is one of the problem with your histamine blockade. So next is uh, some drugs are actually used for bipolar depression. Okay, so can you guys tell me which drug here is used for bipolar? Or generally, what is the drug that you guys know for bipolar always?
Lithium.
Lithium, right? So now it's very difficult to treat bipolar depression. The bipolar patient coming with a depression, it's very difficult to treat. Okay. So now these drugs will actually give a little bit amount of arousal to make that patient feel better. Okay. So what I'm saying is, without putting the patient for a risk of mania, you can give a little bit arousal for the patient. Okay. So there's epiprazole is known to have an effect on the 5-HT1A. Like it's a very small partial agonist. Because it's a partial agonist at that particular area, it can help with all the people who have anxiety. Okay, so you have to remember apiprazole is also your 5-HT2 antagonist. Okay, and your alpha and H1, all the other things also you should remember. But you should remember it is a partial agonist. It's a partial agonist of your 5-HT1A. Okay, so that's why it helps for your anxiety. So now we have like 3 drugs for partial agonist. Okay, but in that only one is given on the first aid. Okay, so you guys have to remember this. It's a partial agonist for your 5-HT1A. So now the next aspect of your atypical antipsychotics is, so let's say the adverse effects. Okay, so typical antipsychotics, because they have anti-dopaminergic effects like your Parkinson's. So Parkinson's is going to be, they will have very much stiffness, tremor, slowness. So the entire Parkinson's is going to be put up together. because of your anti-dopaminergic effect. So next is they can also have galactoria. Okay, they can also have galactoria because I'm talking about typical first. I'll write it down. So typical will be Parkinson's like adverse effect. So next they can have galactoria, which is nothing but your discharge, milky discharge. Okay, that's going to be galactoria. And the nigrostriatal pathway is only responsible for this entire movement and your dopamine synapses and everything and the GABA neurons. Okay, so you have to remember that because they can ask you about the pathways again and again, like mesolimbic is schizophrenia, mesolimbic is your positive symptoms, mesocortical is what? Okay, nigrostriatal is for Parkinson's. Okay, so they will be asking you this pathways. So please remember. So why the galactoria is happening? What is the hormone? Let's start from there.
Dopamine
Prolactin?
is suppressed.
Yeah, anti-dopaminergic. So
Prolactin.
prolactin will increase because generally dopamine will go and inhibit your prolactin, right? So if dopamine is suppressed, it's not inhibiting your prolactin, so prolactin will increase. So now I'm asking which is this pathway. I'll tell you four options. Is it
Nigrostriatal.
noda? Is it mesocortical or mesolimbic or nigrostriatal or tubuloinfundibular?
Tubuloinfundibular.
Tubular infundibular. Okay, so this pathway, because you should remember this pathway is responsible for the inhibition of prolactin by your dopamine. Okay, this pathway is responsible. Tubuloinfundibular is responsible for the inhibition of prolactin by your dopamine. So because we are blocking the dopamine, there is going to be a hyperprolactinemia that will cause galactoria. Okay, that is in the women. So what will the men have?
Gynecomastia.
Gynecomastia. Okay. So because your prolactin is going to be high, what will happen to your gonadotropins?
Decrease.
If dopamine is low, prolactin will be high. If prolactin will be high, gonadotropin will be. The prolactin is known for inhibiting because your increase in prolactin will inhibit your gonadotropins. So now you have to remember the symptoms I want you guys to know is, so this you will again see in endocrine. There's only one picture. So you have to, for those thinking about this diagram, go to your first aid, endocrine physiology with your pituitary gland as a topic. The picture that is given there with respect to like what happens your thyroid regulatory hormone, when it's going to be increasing, what happens to your prolactin? It will be stimulated. And your dopamine will go and inhibit your prolactin. So that picture I want you guys to remember. For right now, in this particular topic, all I want you to know is tubuloinfundibular pathway will be affected. So that will cause your gynecomastia, that is abnormal swelling of your breast in the men, and the women will be having galactoria. Okay. So this is very, very important. And elevation of prolactin will suppress your gonadotropin releasing hormone, which will also result in very, very adverse effects like amenorrhea, starting from amenorrhea. Okay. Decreased libido. Okay. And anorgasmia. Okay. All the androgens and estrogen symptoms you have to remember with respect to this. Okay. So this is your typical antipsychotics. I already told you about antihistamine, anti-alpha 1 and anti-muscarinic and elderly patients. Okay, let's say one more case scenario. Suppose if it is a 50-year-old man, anti-muscarinic effect, you can go for like dry mouth, constipation, urinary retention, all of those things. Suppose you are giving a very, very old patient. Okay, let's say 70-year-old patient, anti-muscarinic, they're asking what is the adverse effect. So I'm giving you as an option. Okay, I'm giving you options. I'm giving you dry mouth, large pupils, okay, confusion. Okay, these are the options. So now they're asking, and let's say one more thing, they're asking which will not be the symptom. So something that is not the symptom, I'm putting it down. Okay, something that's not the symptom at all. Let's say like,
Excuse me, ma'am.
yeah,
Your voice keeps breaking.
My voice is breaking, is it?
Yes, ma'am.
So 1 second. So in that they're asking you to choose which is not the side effect. So in that they're giving you dry mouth and they're giving you large pupil only, I said, right? Large pupil and confusion and something that is not the side effect. Okay, so that is the answer. For right now, what I want you to understand is confusion is one of the anticholinergic side effects. Okay, so you have to remember confusion is one of the anticholinergic side effects in an elderly patient. So please be aware of that. Apart from your urinary retention, constipation, large pupils, your weight gain, your postural hypotension. Okay, so all this you have to keep in mind. Okay, so next is what is tardive dyskinesia? Because that is
Long
also
term.
psych. Okay, long-term psych. So if you can see month to years, there is going to be tardive dyskinesia. So whenever your particular disorder is having an involuntary movement of which part of the body of the face. So let's say your eye, tongue, finger, okay, you're grimacing or you're rocking or you're swaying, okay, face and body. Okay, body will be swaying, face will be your grimace, chewing, eye movements, tongue movements, finger movements, okay. So they've given orofacial. You have to remember it will involve your face and body. So the exact mechanism is still not understood for your tardive dyskinesia, but they are saying that it's because of your dopamine hypersensitivity. So what happens is they are saying when you're prolongedly blocking your D2 for such a long time, very, very long term, because they're given month to years as a scenario, right, for the adverse effect. So what happens is you're having dope hypersensitivity. So because of this dope hypersensitivity, the patients are going to be having the tardive dyskinesia. So there is basically face and body symptoms, which is involuntary movements. Okay. So involuntary movements is very, very important. Okay. So some case scenarios and all, what you can do is, suppose if I want to prevent your tardive dyskinesia, what am I supposed to do? Like they've already given with your benzo and everything. Suppose if I want to switch to another antipsychotic. So what will be my second antipsychotic in mind after this? You can switch to clozapine. Okay, you can switch to clozapine and you because what did I say about clozapine with respect to D2? Is it a good blocker?
Weak.
It's weak, right? So you have to switch to clozapine. That's another antipsychotic that will help to mitigate your symptoms. You instead of going to all the other things, but depends upon the case scenario how bad it is. Okay. So next is extra pyramidal symptoms. I hope you guys know. So I will tell you one by one. So extra pyramidal will be tremor. The patients will have torticollis and the patients will have akathisia and they will be having uh, oculocrisis. Okay, oculocrisis. So these case scenarios. So first of all, what is torticollis? Torticollis is a dystonia only where the person's head turns to one side and it is fixed in a particular position. So my question to you is, a patient is vomiting and I'm giving them a drug and they are developing torticollis. So what is that drug? Metoclopramide. Okay. So metoclopramide basically can cause your torticollis, fixing your head to one position because it's like a spasm. They can cause a spasm. Okay. So now I want you to remember these symptoms: acute dystonia, akathisia, Parkinson's. Okay. So torticollis is where the head is turning to one side and it's fixed in that position. Okay. In your ocular crisis, oculogyric crisis, this term. Okay, so here the person's eye is going to be fixed in your upward gaze. Okay, it is going to be fixed in your upward gaze. Okay, so next is what is akathisia. Akathisia is going to be, they have a very subjective sense of restlessness. So you would have seen certain patients and all fidgeting a lot, certain patients moving a lot constantly. Okay, so these are your akathisias. So the extrapyramidal side effects, how do you manage all these extrapyramidal side effects? Because Parkinson's, I already told you, you have to put them on diphenhydramine or your benztropine, which is nothing but your anti-muscarinic drugs. Okay, you are putting them on anti-muscarinic drugs to combat with your extrapyramidal symptoms. Okay, so then I kept one adverse effect to the last, that is your neuroleptic malignant syndrome. So neuroleptic malignant syndrome is very life-threatening. Okay, so what happens is, guys, till now whatever I'm discussing is only typical antipsychotics. I haven't touched atypical antipsychotics adverse effects at all. Okay, so please remember whatever I told till now is only typical. Okay, so life-threatening syndrome, because it's a neurological emergency. So the patient's case scenario of neuroleptic malignant syndrome will be a patient coming with a altered mental status, and the patient is having a muscle rigidity, and the patient is having a hyperthermia and a autonomic instability. So this is going to be your case scenario of your neuroleptic malignant. So how do you remember this? So you have to remember the problem in the neuro will be autonomic and your A, altered mental status and autonomic. And your malignancy, okay, so M for M, you can remember muscle rigidity and hyperthermia, okay. So now the lab values and all is going to be very bad because it's a very severe disease, right? The creatinine kinase will be elevated. Okay, the creatinine kinase will be elevated. So that creatinine kinase will actually correlate with how severe the disease is. So depending upon the severity, that also will be increasing. Okay, so very commonly they ask neuroleptic malignant syndrome. So you have to remember it. So and atypical antipsychotics we have and typical antipsychotics we have. Okay, so which is better tolerated?
Typical.
Atypical.
Atypical is better tolerated than your first generation of drugs because can you tell me the reason why? I told you the mechanism between the two. Can you tell me why atypical is tolerated better?
They block serotonin receptor.
Selective.
They're partial agonist. Okay, because remember I told you partial agonist, I also underline the drugs. And so you have to, yes, the adverse effect H also, H1 also receptor blockade. Yes, I'll come to that. So first is because atypical, they are tolerated well because they're partial agonist. So if they're partial agonist, okay, uh, they can cause like extrapyramidal adverse effects, okay, because of your partial D2 receptor activity. But if you compare it with your typical, no, it's like a little bit better, okay, little bit better. So next is you also have one of the weak dopaminergic blocker in that whole atypical scenario. So some atypical antipsychotics, what happens is they only have this entire metabolic thing. Okay, they're going to have your weight gain. Why they're having weight gain? When I told you the mechanism of action, what is the receptor?
5-HT2A.
Yeah. So you have to remember because of your 5-HT receptors, they're going to be having your entire metabolic syndrome weight gain. Okay. And if you use, for example, your Olanzapine for clozapine for such a long time, okay, that is very commonly associated with your metabolic syndrome as given here. Okay. So, and apart from that, they can also have like a metabolic syndrome, right? So metabolic syndrome means one by one because they will not tell you directly in the case scenario what will happen to your BP, what will happen to your blood sugar, what will happen to your fat around the waist, and what will happen to your triglycerides, what will happen to your cholesterol levels in metabolic syndrome. One by one. BP,
Increase.
blood sugar,
Also increase.
fat is also increased. Okay. Triglycerides is going to be very up, both
Also.
are abnormal. Okay, so this is going to be increasing the risk of what all problems. So first, they will have a cardiovascular disease, right? So let's start from stroke, your CVD, diabetes. So that's why HbA1c should also be monitored in all these patients. Okay, what will happen in the liver? Why do we need a liver? Very good, fatty liver. So fatty liver can be there. So liver function test is good for your liver enzymes. Okay. So what is the particular side effect I told for clozapine that you have to remember very, very severe?
Agranulocytosis.
Agranulocytosis. Okay. So otherwise clozapine is a weak D2. You have to remember. So next is cardiac. I think QT prolongation they would have given. QTC prolongation. So QTC prolongation, which drug will cause, they will ask. You have to remember your Zipra. Ziprasidone is known for your QTC prolongation, and they also have a very, very increased risk of three things. One is QT prolongation means which ECG finding you have to remember with respect to your rhythm disorder. Tosadis D pointers. Okay. So you have to remember your Tosadis D pointers. Tosadis D pointers is nothing but you are having a polymorphic QRS. What does polymorphic QRS means? You have like a variable. So the QRS is not going to be of same size. Okay. Sometimes they're very small, sometimes they're very high. So it's going to be like this. Okay. So it's polymorphic. Okay. Different morphology of QRS. So I want you to remember QT prolongation is seen with Zipra, and they have like a ventricular tachycardia one presentation. Tosadis D pointers another presentation. That's why whenever you are putting an antipsychotic, you should also do a ECG for them for a monitoring case scenario. Okay. So next is antipsychotics. They can cause a lot of health problems, but they are known for decreasing your threshold of the seizures also. Okay, because I told you all the other effects, but you have to remember seizures. They can cause because they decrease the threshold of seizures. So always ask the history of seizures before putting them on drugs because you have to adjust the dose accordingly. Okay, so that is about your antipsychotics till now. So shall I ask you certain questions on antipsychotics before going to next topic? Let's say we have a 30-year-old man. He is coming to the hospital with paranoia. And he is very, very afraid that his family is trying to poison him. So he is also hearing voices. Okay. He's also hearing voices and he's also responding to the voices. Okay. He's hearing voices. And the voices is telling him that his family wants him to move out of the house. So now, what will be the medication that will be appropriate for treating this particular condition? Okay. So I will give you options. Like I didn't discuss this when I was talking. That's why I gave the scenario. Will that be your lithium? Or will it be your diphenhydramine? Or will you give olanzapine? I want you guys to remember auditory hallucinations. You have to go along with olanzapine. Okay. So when you go back to the Tableau column, they would have given a lot of disorders. For example, let's say schizophrenia, okay, OCD, Tourette's, Huntington's, okay. But I want you to remember, please write olanzapine is used for auditory hallucinations. I'll tell you the other areas also. The other questions, I mean, other options I gave was diphenhydramine. That is an antihistamine for allergies, okay. And lithium is used for
bipolar depression.
Bipolar, right? Okay, fine. So that is good. So next is, let's say we want to do a very common routine test. Okay, that should be ordered for a patient taking an atypical antipsychotic. For example, he's on olanzapine. So I'm saying that he has to go for a routine test. What will be the test I should order for him?
Profile HbA1c.
Okay, fine. So olanzapine, you should always remember your metabolic syndrome. So you should put them on HbA1c screening so that you are aware. Okay. But apart from that, I want to ask about this. For which echo will be ordered? Ziprasidone you have to order because I told you QT prolongation echo. Okay. So next is Let's say we have a patient who is around sore throat. Patient is having a dry cough and rhinorrhea for the past 4 days. Sore throat, dry cough, rhinorrhea. So he has a history of schizophrenia. Okay, but the physician is not sure which medication he's taking, and he's not remembering the names also. The physician wants to give like a supportive therapy, like he's recommending supportive therapy and he's sending him home. Okay, so 3 weeks later, the first presentation is only sore throat, dry cough, rhinorrhea. He has a history of schizophrenia, but the physician is not sure of what medications he's taking because the patient can't remember. 3 weeks later, the patient is coming to the emergency department in a very, very much worse scenario. And the CBC is also showing a low WBC. So, what was the antipsychotic that he was taking?
Clozapine.
Yeah, so this is agranulocytosis, clozapine. Okay, so next question. The patient is having schizoaffective. The patient is having a schizoaffective disorder, okay, and she's also having anxiety symptoms.
क्या बाबा
When choosing a medication for anti-anxiety, because you have to choose a medication that is having anti-anxiety effects, right? So, which will be the medication that you will choose from today's class? The 5-HT1A partial
High
agonist.
serotonin effects.
Risperidone.
Yes. So not risperidone, aripiprazole. Okay, because I told you your aripiprazole is going to be an atypical antipsychotic that not only acts at your D2, but it is also your 5-HT1A partial agonist. Okay, so you have to remember it's good choice for anti-anxiety. Okay, so next is, let's say we have a patient who is having urinary retention, dilated pupils, and dry mouth and constipation. By now, you guys will know what I'm going to ask. So, which drug is causing this adverse effect? All the anticholinergic, like most commonly also you can tell. I'll give you options. So, is it ziprasidone? Is it chlorpromazine? Or is it risperidone? Anticholinergic side effects? Chlorpromazine, because you have to remember typical antipsychotics are associated with anticholinergic adverse effects when the patient, which is basically the presentation of the entire case scenario. I hope your antipsychotics are clear. I want you guys to re-go through this and remember and go ahead and try your questions. Okay. So next concept is, apart from antipsychotics, your antidepressant is the next important topic. I think they have not like given it like fully together. They have given it like separate. Okay, it's starting from here. So antidepressants is used to, depression is basically you have sadness and loss of interest in a normal activity. Okay, so now it's majorly used to treat your major depressive disorder, your schizoaffective, OCD, anxiety. We have a lot of scenarios. Okay, but first, when you look into your mechanism of action, starting with your SSRIs and SNRIs, okay? So why is serotonin important is because it's very important in maintaining your mood balance. And suppose imagine a patient is having low serotonin in the body. If there is going to be low serotonin, then the patient, they have found out that it's linked with your depression. Okay, and norepinephrine is actually known for improving your energy and also your attentiveness. Okay, so your norepinephrine is known for improving your energy and attentiveness, and your serotonin is known for maintaining the mood balance. So when the serotonin is low, the patients have been linked with your depression. So now the serotonin is nothing but a neurotransmitter, right? Even norepinephrine is also a neurotransmitter. All that is going to be working in your neurosynapse. That's why they have given you serotonin and your noradrenaline put up together. Okay, so the longer the longer a neurotransmitter is basically staying in that particular synapse, the longer the effect is going to be. So now SSRIs are actually known for blocking your reuptake of your serotonin. SSRIs are known to block your reuptake of your serotonin, the 5-HT reuptake. Okay. And SNRIs, they work by blocking the reuptake of both serotonin and your norepinephrine. Okay. So now you can see SSRI is here, SNRI is there in both. So this is a basic difference that you have to know. So now, even though the entire effect is blocking the reuptake of your neurotransmitters, okay, so it's going to be very, very quick when you start the drug, okay, but certain drugs will take a lot of time, like a few weeks for that clinical effect to be shown, okay. So suppose if they're asking you, like, why certain drugs are showing like very in the starting time itself, like it's starting quickly, but why the clinical effects are shown very late? Why the clinical effects are shown very late? You have to remember it's because we have a down regulation of your 5-HT1A receptors. Okay. You have to remember whenever the blocking of reuptake of neurotransmitters are happening, okay, it's going to be very, very quick, but it will take some time, like few weeks to measure the exact clinical effect is because the 5-HT1A, okay, which is your presynaptic receptor. I think it would have been marked here. It's given there in the first year. I want you guys to remember 5-HT1A is going to be down regulated. Okay. So next is what is happening with respect to this down regulation. I'll explain here. Okay. So whenever, let's say the presynaptic, I told you the 5-HT1A is nothing but your presynaptic receptors. Okay, it's an autoreceptor. It is known for inhibiting your serotonin actions, your serotonin neuron, the serotonergic neuron, okay, by an autoregulatory mechanism. So over time, what happens is when we are increasing your serotonin synapse, because we are inhibiting the reuptake of the serotonin, right? So when the serotonin synapse is increasing, don't you think this whole receptor is going to be like down regulated? So that's why whenever you're inhibiting the reuptake of your serotonin, the drug that you're giving, when it's inhibiting the reuptake of serotonin, it's going to result in the down regulation in the number of the presynaptic 5-HT1A. Okay, I will tell once more. 5-HT1A is known for inhibiting your serotonergic neurons. Okay, serotonergic neurons. So because we are inhibiting your serotonin uptake, the serotonin inside the synapse will increase. So over time, this will downregulate your receptors. Okay, it will downregulate your receptors. Okay, so that is why we have a decreased inhibition of the neuron. That is why we have decreased inhibition of the neuron. And we have increased effect of your serotonin. Like, could you guys understand what is happening with respect to the entire concept? Okay. So now you have to know what is your serotonin partial agonist reuptake inhibitors. So can you guys tell me examples of serotonin partial agonist reuptake inhibitors? Is that given separately? Okay, fine. So there are like two drugs right now for your serotonin partial agonist. Both are starting with V only. One is vilazodone. Another is going to be ortiozetin. These are your serotonin partial agonist reuptake inhibitors. Where means postsynaptic 5-HT1A receptors. Okay, they are known for increasing your serotonergic activity in the brain. Postsynaptic 5-HT1A receptors, they are known for increasing your serotonergic activity in the brain. So when we are giving this SPARI, it's called a SPARI. Okay, serotonin partial agonist reuptake inhibitors. when we are putting the patient on this, okay, what's going to happen is they act as an SSRI. They will act as an SSRI, but they also have a partial agonist activity at your 5-HT1A receptor. They act as a SSRI, that is stop the reuptake, okay, but they also act as a 5-HT1A. They also have this activity of 5-HT1A agonist, okay. So that's why you have a combined effect. That is, you're also increasing your serotonin in the synapse and it is available for the brain, okay, and the decreased of depression symptoms are seen, but the 5-HT1A is also like agonist, that is also seen. So this is like very expensive because the generic forms are still not available. So you can remember your Vortioxetine and Vilazodone, okay, that is your SPARIs, okay. So next is with respect to depression, how your monoamine oxidase inhibitors, your tricyclic antidepressants, how are they going to help in this condition? Okay. So starting with your tricyclic antidepressants. Wait, I'll actually go to a blank space. So your tricyclic antidepressants, what was the mechanism of action? I told you SSRIs and SNRIs, and if you guys remember in the serotonergic and your noradrenergic neuron, they would have given TCA in both areas. Tricyclic antidepressants is very, very similar to your SSRI and your SNRI. Okay, but I also told you one more thing when I taught you antipsychotics. Like antipsychotics, they work like your TCA. So what did I tell? What is that? 3 inhibitors? Your ham.
Acetylcholine and muscarinic.
Yeah, right. Very good. Okay, so H1 receptors, alpha 1 receptors, and your muscarinic effectors. Okay, so TCA, you guys should like have the first aid on you when I'm talking this so that you can look at the diagram. Serotonergic and your noradrenergic, both the neurons, if you can actually see that particular synapse, okay, the TCAs will be given in both areas. They're very, very similar to SSRIs and SNRIs, but they have this extra action. This means that they have a greater adverse effect profile. That's all. Okay. So when you are having all these, you have a lot of adverse effects. So patients taking these medications can have antihistamine. The same thing I told you. But apart from the adverse effect profile, TCAs are also used for neuropathic pain. They're very commonly used for neuropathic pain and they're also used for fibromyalgia. Okay, I want you guys to remember this because they very commonly question these two aspects. Okay, so TCA is used for neuropathic pain and your fibromyalgia apart from your antidepressant. Okay, so next is your monoamine oxidase inhibitors. So monoamine oxidase inhibitors, if the monoamine oxidase inhibitors is actually seen, it's going to elevate your catecholamines. That means it's elevating your serotonin also hand by hand. Okay. So instead of, they're not blocking your reuptake and all, they're just directly elevating your catecholamines and your serotonin. So if they're not blocking your reuptake, what is your monoamine oxidase doing? They are inhibiting your monoamine oxidase only. So what is your monoamine oxidase responsible for? It is responsible for converting your epinephrine and your norepinephrine and your serotonin into your inactive metabolites, So this monoamine oxidase is important for converting all this into your inactive metabolites. So when we are inhibiting this monoamine oxidase, the work is already done. You're increasing your serotonin value and your catecholamines value. Okay. So this is actually not that frequently used because we have a lot of dangerous side effects. I will discuss all these side effects one by one after finishing mechanism of action. Okay. So next is atypical antidepressants. Okay. So atypical antidepressants, we have 3 drugs. One is bupropion. Another is your mirtazapine. Another is your trazodone. Okay. Bupropion, mirtazapine, and trazodone. So what happens is bupropion will inhibit your reuptake of your dopamine and your norepinephrine. So this will inhibit your the reuptake of your dopamine and your norepinephrine. Okay. So it is also used apart from Bupro, like apart from your depression, it is also used for smoking, like to stop smoking cessation. Okay. So depression and smoking. Okay, meta. So now your mirtazapine is nothing but your antagonist at your central alpha 2. It is an antagonist at your central alpha 2. Okay, that means it can increase your catecholamines and your serotonin because when you're inhibiting your alpha 2, okay, what does your inhibition of alpha 2 mean? Go back to the diagram given. Okay, so please remember when you are inhibiting your presynaptic alpha 2 receptor, you are disinhibiting your norepinephrine, dopamine, and your serotonin release from the presynaptic neuron. So when you're inhibiting your alpha 2, you are disinhibiting your norepinephrine, dopamine, and your serotonin release from your presynaptic neuron. So meta is also one more weak antagonist. Okay. So it's a very, very weak. I'll write till here. So it is a weak antagonist at your 5-HT1. It is a weak antagonist at your 5-HT1. Okay. And it is a strong antagonist at your 5-HT2 and 3. Okay. So, and one more thing, it is an antagonist at H1 also. Okay. So I think I've put everything together. Yeah, that's it. So now mirtazapine is an antagonist of alpha 2 and it will disinhibit your norepi, dopamine and serotonin. That means all that is increasing. So next is it is a weak antagonist of 5-HT1 and strong of 5-HT2 and 5-HT3 and your H1. That's why patients will have sedation. Okay, so sedation effect, and it can also be useful. Suppose imagine there is a patient who is having depression and they cannot sleep. So there it is going to be useful, right? Suppose mirtazapine is also known to increase your appetite. It will increase the appetite. So for patients who cannot sleep and patients who are not hungry with your depression, mirtazapine will be helpful for them. Okay, hunger and sleep. So next is trazodone. Trazodone will basically bind to your 5-HT2, okay, and it will be an antagonist of it. So it inhibits your 5-HT2, okay. So initially they thought that trazodone is very similar to your fluoxetine, that is your reuptake of your serotonin blocker. They thought trazodone is like that, but right now they are saying that it's 5-HT2 receptor antagonist, okay, and it is also blocking your alpha 1 and it is also blocking your H1, okay. So I want you guys to remember these all receptors, then only if you're asking adverse effects you will understand why it is happening, okay. So please go through all these concepts one more. So now I'll start with your adverse effects one by one. So let's say the common adverse effect of antidepressants is the patients usually say weight gain. The very, very common that I've seen is starting with weight gain. The patients also have like nausea, vomiting, drowsiness. So the general nausea, vomiting, drowsiness, and they can't, even after taking tablets, some people, they still have sleep disturbances. Okay. Some people have sexual side effects. Okay. So now these are the most common adverse effects. And last is headache. These are the most common adverse effects. Okay. So now sexual adverse effects, I'll talk about one by one. So this nausea, vomiting, drowsiness, and all is like um, very common. Weight gain is also very common. We'll talk about one by one, starting with potential sexual adverse effects. So you have to grade, okay, the side effects. Let's say a patient is having a low libido. Some patients are having delayed ejaculation. Okay, so which drugs and all will cause sexual adverse effect? Like which drugs will cause high risk? High risk for sexual adverse effects means tricyclic and your SSRIs and your SNRIs and your monoamine oxidase inhibitors. Okay, so I want you to remember these are all high risk. Okay, they increase the risk of sexual adverse effects. Low risk is going to be your bupropion and your mirtazapine. Bupropion and mirtazapine will decrease the risk of your sexual adverse effect, or let's say not decrease, low risk of adverse effects when compared to your TCA, SSRI, SNRI, and monoamine oxidase inhibitors. Okay, so it's very, very important for you to counsel the patient on the risk factor before starting the medication because it's going to be affecting them. So can anybody tell me, with the concept that I've taught you in antipsychotics, why sexual adverse effects is actually seen with your differences in dopamine and serotonin?
Blocking dopamine.
Anti-serotonin.
Okay, basically, dopamine means, does dopamine make you happy or sad? Dopamine is known for initiating a sexual behavior. Okay, dopamine is known for initiating your sexual behavior because motivation. Okay, let's just remember motivation. And serotonin is known for inhibition of your sexual behavior. Okay, this is initiation, this is inhibition. Okay, dopamine will initiate your sexual behavior because of the motivation, and serotonin is thought to be having like a inhibitory effect. Okay, so sometimes and all there are a lot of studies which says that your SSRIs, whenever you inject them like directly into your lateral hypothalamic area, when you're injecting into your hypothalamic lateral area, they are causing delayed onset of sexual activity and ejaculation. So you have to remember SSRIs, serotonin, lateral hypothalamus, they are decreasing. Okay, they are decreasing your onset of sexual activity and your ejaculation. That is a very common adverse effect in your antidepressants. Okay, so the role of serotonin in sexual function is little bit complicated because it depends upon what all receptors are being stimulated. For example, let's take what is priapism.
Painful erection.
Painful erection. So priapism, that is, priapism erection will actually be more than 4 hours. Okay, that is the cutoff value that you have to look into the case. So trazodone is known to cause your priapism erection that is lasting for longer than 4 hours. So this also they are saying because it is mediated by your alpha adrenergic antagonism. Because you have an antagonist, right? It's an alpha adrenergic antagonist, postsynaptic. So when you study about reproductive, you should know. So priapism is very dangerous because the patients are going to have, imagine there is too much of blood flow to the penile tissue. Okay. And because the patients are having erection for more than 4 hours, right? So what does erection of 4 hours means? That you're having increase in blood flow. So when there is too much of blood flow, what will happen to the penile tissue? They can, okay, when priapism is actually dangerous because you have to know increase in blood flow with your priapism case scenario will cause ischemia of your penile tissue. Okay, it will cause ischemia of your penile tissue if it is not lasting long enough. What I'm saying is if the blood flow is not lasting long enough, it can cause ischemia. That's why if a patient is coming with priapism, it's very, very necessary for you to drain the blood because you have to prevent your permanent damage to that particular area. And suppose if the erection is less than 4 hours, okay, suppose if the erection is less than 4 hours, I told you more than 4 hours, you have to directly drain because we do not want permanent damage. Okay, so less than 4 hours means what will be the drug? Any sympathomimetic example? Phenylephrine. Okay. So please remember more than 4 hours, you have to drain the blood, all the increase in blood flow because if it will not last long enough. So it will go for ischemia. Less than 4 hours, you have to give injections. Okay. Like intracavernosal injections should be given. Cavernosal of your sympathomimetic drug. For example, I'm telling you phenylephrine. Okay, so now I told you that priapism is seen with trazodone, and they are thinking it's because of your alpha antagonism. It's very dangerous because the blood flow, increase in blood flow will not last long enough because of ischemia. And more than 4 hours, you have to drain. Less than 4 hours, you have to inject sympathomimetic drug. For example, your phenylephrine in intracavernosal. Okay, so that is sexual adverse effect. So next is what is happening is sometimes they can give you all these scenarios of depression and antidepressive medications. So they can ask about serotonin syndrome. Okay. So what is serotonin syndrome is because we are blocking the reuptake of serotonin. Okay. There is going to be too much of serotonin in the body. So first, what does your serotonin do to your mental status? So it will have a very disoriented, restlessness, agitation. Okay. Because all these words and all is given in the first aid. I want you guys to remember that only. So right now I'm just orienting you guys. So they will have a problem with the mental status changes. Okay. Like a disorientation, restlessness, agitation. So they have an autonomic change. So autonomic change will be tachycardia, hyperthermia, diaphoresis, all these things. Your mental changes will be restlessness, agitation, disorientation. So next is neuromuscular. Neuromuscular, what will be the changes? Hyperreflexia, clonus, hyperreflexia, clonus, and the patients can have tremor. That is neuromuscular. So you have to remember it's an emergency of mental, autonomic, and neuromuscular. It's very life-threatening. So what are the two drugs that we should not use? Like SSRI should not be used with what?
Monoamine
Yeah.
inhibitors.
So SSRI should not be used with monoamine oxidase inhibitors because if you use them in combination, the serotonergic medications, so you have to remember serotonin syndrome can happen. Okay. So this is one crisis, like a red flag. So I'm saying that when you put on antidepressant, the patients can have hypertensive crisis. So which medication can cause hypertensive crisis?
MAO inhibitors.
Yeah, your monoamine oxidase inhibitors. So monoamine oxidase inhibitors, when they are taken along with the foods that is very, very rich in your thiramine. So
Correct.
thiramine is present in what all food?
Smoked meats and red wine.
Yeah. So cheese, meat, all the fermented foods, wine. Okay, so these all foods will have thiramine. So what if they have thiramine means thiramine is an amine. So they are known to increase your catecholamines. Okay, they are known to increase your catecholamines. That's why you should remember monoamine oxidase inhibitors when they are taken along with thiramine. So because they are increasing your catecholamines and normally monoamine oxidase, okay, normally what you should remember is monoamine oxidase, that is your A form, not the B one. Where is the monoamine oxidase B used? Parkinson's. Okay. So here I'm talking about monoamine oxidase A, not B. Okay. Monoamine oxidase A, normally in the intestine, it is converted, it is it converts most of your dietary thiramine into like an inactive metabolite. Okay. So that's why you should remember normally in the intestine, we have monoamine oxidase A. So that will convert all the thiramine that you take through your diet, like for example, cheese, meat, food, and your wine. Okay. It will convert them into an inactive metabolite before it's reaching your circulation. But because you're giving a monoamine oxidase inhibitors, so that is not going to convert your thiramine to your metabolites. So the patients are increasing, they're having an increase in your catecholamine. So catecholamine excess is there. So too much of catecholamines, what will happen to your alpha activity?
Increase
So they
blood
will
pressure.
act on your, yes. So they will act on your sympathetic alpha adrenergic receptors. So they are going to cause a vasoconstriction. So therefore, there is a hypertensive crisis. Okay. So the thiramine in the blood circulation is actually converted to your inactive metabolites by your monoamine oxidase. Because we are giving monoamine oxidase inhibitors and you are eating cheese, for example, so that is going to increase your catecholamines and catecholamines will act at your alpha adrenergic receptors, sympathetic, and the patients will be having a vasoconstriction. Okay. So next is withdrawal. Withdrawal is when you're decreasing the dosage, you have to taper the dosage. Suppose if you are just stopping it, for example, let's say SSRIs. SSRI withdrawal symptoms will be like general only, nausea, vomiting, fatigue, dizziness, okay, headache. So all these general symptoms. I want you guys to remember discontinuation also can be one of the scenario that can be questioned for you. So now some patients with your depression, they can have bipolar also. Okay, the patient will be talking about the feeling of sadness and the loss of interest in everything. Okay, which is meeting your criteria of major depressive disorder. But the next thing you should ask them is about the family history or your personal history of manic episodes, all the map. So that means you should ask whether you have a decreased need for sleep, whether you have raising thoughts in your mind, okay, raising thoughts in your mind, whether you have a feeling of elation, whether you have increased productivity. So you should ask about all the manic episodes history whenever you're seeing a major depressive disorder. So whenever they're saying they have weight loss or gain or lack of appetite, they don't have energy, they don't have interest, you should ask your family history and personal history. It's very, very important before you start on an antidepressant medication because it will always, if there is a patient on an antidepressant medication, it can trigger a hypomaniac or a manic episode. Okay, because why it is happening is basically they are affecting your serotonin receptors. Okay, like say they're having an alteration with respect to your serotonin. Okay, so that means alteration in your dope. So that's why you should always remember alterations in the serotonin, meaning alterations in your dope phenomenon. So that's why they can have like a hypomaniac or a maniac episode. So you have to be very careful. This phenomenon is even more commonly seen when uh, with your TCAs and your monoamine oxidase inhibitors than your SSRIs. Okay, so your TCAs and monoamine oxidase inhibitors causing your maniac hypomaniac is more common when compared to your SSRIs. So that's why any major depressive MDD, you have to ask about family history. So next is, can the patient have suicide as a risk factor with your medication overdose? Yes, they can always ask you like SSRI, SNRI, monoamine oxidase, overdose, okay, serotonin syndrome, that can be asked, and they can also ask suicide risk. Okay, suicide risk can be questioned. And next is with respect to your tricyclic antidepressants overdose. Okay, like any other antipsychotics, I told you ham blockade. So please remember ham blockade. So next is they block your GABA receptors. Because you're blocking your GABA receptors, the patients are going to be having convulsions. Okay, because GABA is what? What is GABA?
Inhibitory neurotransmitter.
Yeah, so it's an inhibitory, central inhibitory neurotransmitter is blocked means that means your central nervous system hyperactivity will be happening, right? Because you don't have inhibition. So because your inhibitory neurotransmitter is blocked, your central nervous system will go for a hyperactivity and that will predispose them to seizures, that is your convulsions. Okay. So next is cardiotoxicity. So why is there a cardiotoxicity means because they will inhibit your myocardial voltage gated sodium channels that will lead them to arrhythmias. It will be very lethal. And they also they are known for your inhibition of your alpha adrenergic, right? So they block your alpha adrenergic. So that is going to contribute to your entire CVS collapse. Okay. So because if you're blocking alpha, what will happen to the vessels? Dilatation or constriction? Will
Construction.
have
Dilatation.
dilatation. Alpha will cause constriction. Da. Okay, so now inhibiting your alpha will cause vasodilatation. So what you should remember is first is ham blockade, second is GABA blockade convulsions, third is myocardium voltage gated sodium channel, so arrhythmia. Fourth is your alpha blockade, adrenergic alpha blockade, vasodilatation. If there is a vasodilatation, why it is a problem means your peripheral vasculature, no, they cannot compensate. They cannot compensate for the decrease in cardiac output. A patient is having a decrease in cardiac output and the patient is having arrhythmia. So they don't have like a compensatory effect. Okay, it's not going to be good. So that's why you should always remember these 4 adverse effects. So next is always look at the electrocardiogram, because if you're having the blockade of your voltage gated sodium channels, what will happen to your QRS? Think this way.
Prolonged.
First, yeah, it will be prolonged. Okay, so go back to your cardiology physio. Okay, so if you look at your myocardial action potential, you'll be having first sodium, next calcium, first sodium, next calcium, then potassium, then your rest phase. Okay, depolarization, calcium will be a little bit plateau, then your repolarization. Depolarization, after that only you're having your action potential, right? So when this whole total sodium is blocked, okay, so if you're blocking your sodium, so then the patients are going to be having a prolongation, because they don't have, imagine the patients are going to have a QRS prolongation. So what should be given along with this to increase your myocardial sodium conduction means, I'll erase this, because the patients will have QRS prolongation, they should be given sodium bicarbonate.
Sodium bicarbonate.
Yeah, because you have to increase your myocardial sodium channel, right? The conduction, and it will also alkalinize your urine. How will your alkalinization of urine help? Because it will increase your TCA excretion. Okay, alkalinizing the urine will increase your TCA excretion, and it will also increase your sodium channel conduction. It will increase sodium conduction, increase your TCA excretion. So that's why you should always remember this. One more thing, what will happen if TCA and phenytoin is given together? Okay, so phenytoin is actually known for one thing. It will weakly block your sodium channels in the myocardium. Okay, maybe because it's blocking your sodium, your seizures can go down, but your ventricular fibrillation possibility is there. Okay, so you have to know you should not give a TCA along with phenytoin, because the seizure possibility will go down, but your ventricular fibrillation is possible. Okay, so in the pharmacology, your antipsychotics are very, very, very important. Okay, I don't think there is any other dense pharmacology apart from antipsychotics and your neuro. So others are very easy. So please study this one more and solve questions. I'll continue the rest concepts. We have touched upon all of the concepts a little bit today. For example, what we have done today is antipsychotics and your antidepressants. Okay. So I think before starting your immunology questions, immunology is a small topic. Okay. So I will be discussing about your mood stabilizers and your anxiety drugs and your hypnotic drugs. These won't take much time. Then we will go about your non-pharmacological treatment, like your positive behavior therapy and all of that. Okay. So I'll see you guys tomorrow at same time. Thank you, guys.
Thank you.